Hierbij open ik deze academische zitting, waarin Jacobus de Geus het academisch proefschrift getiteld Spinal Cord Stimulation Paradigms in Experimental Painful Diabetic Polyneuropathy, Plasticity of the Nociceptive System in het openbaar zal verdedigen. Mag ik u verzoeken een samenvatting te geven van uw proefschrift.
Beste prorector, leden van de corona, beste vrienden, familie en collega's. In de komende 15 minuten zal ik mijn proefschrift met als titel Spinal Cord Stimulation Paradigms in Experimental Painful Diabetic Polyneuropathy, Plasticity of the Nociceptive System aan u presenteren. Een kort overzicht. Ik zal eerst beginnen met een kleine introductie van het onderzoek en daarna iets vertellen over het literatuuronderzoek wat we hebben gedaan. Daarna zal ik aan de hand van 4 verschillende hoofdstukken de gedane experimenten en de daarin behaalde resultaten aan u laten zien. Suikerziekte, ook wel diabetes genoemd, zorgt in 1 op de 4 patiënten voor pijnsymptomen. Deze symptomen beginnen vaak in het uiteinde van de voeten, maar breiden zich later uit naar de handen en ook de buik. Dit noemen we pijnlijke diabetische polyneuropathie, ook wel PDPN. Door de hoge hoeveelheden suikers in het bloed ontstaat er schade aan de zenuwcellen. We zien dan ook bij PDPN-patiënten dat het aantal zenuwen in de huid is afgenomen. Door de schade aan de zenuwen ontstaat er een pijnsignaal die zich naar het brein gaat begeven. Voordat het pijnsignaal in het brein kan aankomen, moet het eerst over de ruggenmerg. En in deze ruggenmerg bevindt zich een poort. Hier ziet u een dwarsdoorsnede van de ruggenmerg, waar de poort zich bevindt. Als de poort is gesloten en het pijnsignaal komt aan in de ruggenmerg, dan kan het pijnsignaal er niet doorheen, kan het ook niet door naar het brein en kan de pijn dus ook niet worden ervaren. Echter, als deze poort open staat, kan het pijnsignaal wat aankomt in de ruggenmerg wel er doorheen, kan dit door naar het brein en zal het pijnsignaal dan ook worden ervaren. We zien dan bij PDPN-patiënten dat de poort in de ruggenmerg vaker open is in vergelijking met gezonde mensen. Een belangrijke factor bij het openen en sluiten van deze poort is ontsteking. Als het pijnsignaal aankomt in de ruggenmerg, dan worden ontstekingscellen actief. En deze ontstekingscellen die kunnen we zien als een soort brandweermannen, die eigenlijk een soort brandje komen blussen. In gezonde mensen is dit dus een positief effect en zorgt dit voor herstel. Deze ontstekingscellen scheiden stofjes uit die we kunnen onderscheiden in ontstekingsstartende en ontstekingsremmende stofjes. De balans tussen deze ontstekingsstartende en remmende stofjes bepaalt of dat de poort in de ruggenmerg open of dicht is. Zo is een balans naar de ontstekingsremmende stofjes ervoor kan zorgen dat de poort dicht is en het pijnsignaal er dus niet doorheen kan. Aan de andere kant is een balans die naar de ontstekingstartende stofjes is, kan ervoor zorgen dat de poort wel open staat. Het pijnsignaal dus wel door de ruggenmerg kan en dus ook door de patiënt kan worden ervaren. Een belangrijke behandelmethode van pijnlijke diabetische neuropathie is ruggenmergstimulatie. En hierna zal ik dit ook vaker spinal cord stimulatie of SCS noemen. Bij ruggenmergstimulatie plaatsen we een elektrode bovenop de ruggenmerg en een soort pacemaker boven de bil. Omdat dit een invasieve procedure is, doen we dit eigenlijk alleen op het moment dat andere behandelmethodes niet meer werken. En bij ruggenmergstimulatie geven we elektrische stimulatie aan de ruggenmerg af met als doel de poort in de ruggenmerg te sluiten. We kunnen deze elektrische stimulatie geven in verschillende golfvormen. De meest gebruikte en voorkomende golfvorm is conventioneel. En hierbij worden ongeveer 50 pulsen per seconde afgegeven aan de ruggenmerg. Tegenwoordig zien we dat ook een andere golfvorm die steeds vaker gebruikt wordt, de hoogfrequente golfvorm is. En bij hoogfrequent worden tot 10.000 pulsen per seconde afgegeven. Daarnaast is recent een nieuwe golfvorm bedacht, genaamd Differential Target Multiplexed, ook wel DTM-stimulatie. En dit is eigenlijk een combinatie van de conventionele en de hoogfrequente golfvorm. En deze golfvorm is specifiek heel interessant omdat gedacht wordt dat deze de balans tussen die ontstekingstartende en remmende stofjes kan herstellen en op die weg de poort in de ruggenmerg kan sluiten. Om een overzicht te krijgen van wat er al bekend was, hebben we eerst een literatuuronderzoek gedaan en daarin gekeken naar de effecten van deze verschillende stimulatiegolfvormen op de ontsteking in de ruggenmerg. Dit hebben we gedaan door literatuur te onderzoeken waarin pijn werd geïndiceerd in een dier. En vervolgens één of meerdere van de golfvormen werd toegepast om de pijn te behandelen. en vervolgens ook de balans tussen de ontsteking startende en remmende stofjes in de ruggenmerg werd gemeten. We zien dat op het moment dat de pijn wordt geïndiceerd, dus het pijnmodel wordt gegeven aan het dier, er een balans ontstaat naar de ontsteking startende stofjes. Wat interessant is om te zien dat als vervolgens de conventionele golfvorm werd gebruikt, dit effect nog werd versterkt. Dat kan er op het lange termijn in resulteren dat de poort in de ruggenmerg sneller open gaat en dat dit dus zorgt voor een makkelijker pijnsignaal naar het brein toe. Aan de andere kant hebben we gezien dat hoogfrequent en DTM-stimulatie zorgt voor een balans naar de ontstekingsremmende stofjes. Dat kan er op het lange termijn dus voor zorgen dat de poort juist sluit en dat het pijnsignaal kan worden gestopt. Wat ons ook opviel uit het literatuuronderzoek is dat er niks bekend was over de effecten bij pijnlijke diabetische neuropathie. Oftewel, de pijnmodellen die werden gebruikt waren anders. En om meer inzichten te krijgen in deze effecten in pijnlijke diabetische neuropathie hebben we 4 verschillende experimenten gedaan waar ik u nu in ga meenemen. De eerste daarvan is dat we hebben gekeken naar de effecten van langdurige ruggenmergstimulatie in pijnlijke diabetische neuropathie dieren. Vanuit het ziekenhuis weten we dat de effectiviteit van ruggenmergstimulatie met conventionele settings, dus de 50 pulsen per seconde, na verloop van tijd kan afnemen in de patiënten. En daarom vroegen wij ons af, wat is het effect van langdurige conventionele ruggenmergstimulatie in pijnlijke diabetische neuropathie-dieren? Allereerst op de pijn, maar daarnaast ook op het aantal zenuwen in de huid en de ontsteking in de ruggenmerg. Om dit onderzoek te doen maken we gebruik van een diermodel waarin diabetes wordt geïndiceerd door middel van een injectie. Na verloop van tijd meten we dan de gevoeligheid in de achterpoten van deze dieren. Dit doen we met de Van Vrij-test die je hier ziet afgebeeld. Bij de Van Vrij-test houden we filamenten van verschillende dikte tegen de achterpoot aan totdat zij ombuigen. Of totdat het dier zijn poot als reflex terugtrekt. Hoe dikker het filament is waarbij het dier zijn poot terugtrekt, hoe minder gevoelig het dier is. Maar hoe dunner het filament is waarbij het dier zijn poot terugtrekt, hoe gevoeliger het dier is. En dat resulteert in deze grafieken. Hoe hoger op deze grafiek, hoe minder pijn de dieren hebben en hoe lager op deze grafiek, hoe meer pijn de dieren hebben. In dit onderzoek hebben we gebruik gemaakt van 2 verschillende groepen. 1 groep die wel werd gestimuleerd en 1 groep die niet werd gestimuleerd. En hier ziet u de situatie voordat we zijn begonnen met het geven van de stimulatie. En belangrijk is om te vermelden dat op dit tijdspunt alle dieren PDPN hadden, oftewel alle dieren hadden pijn. Vervolgens ziet u hier de situatie tijdens de stimulatie. En u kunt duidelijk zien dat de dieren die wel werden gestimuleerd minder pijn hadden dan voordat ze werden gestimuleerd. Maar dat de dieren die niet gestimuleerd werden, niet minder pijn kregen. En het sterretje boven deze grafiek laat zien dat iets wetenschappelijk is aangetoond. Vervolgens hebben we gekeken naar het aantal zenuwen in de huid van deze dieren. En het was interessant om te zien dat in de gestimuleerde dieren er meer vezels aanwezig waren dan in de niet gestimuleerde dieren. En dat kan dan ook een verklaring zijn waarom deze dieren minder pijn hadden. Daarnaast hebben we gekeken naar het aantal ontstekingstartende stofjes in de ruggenmerg van deze dieren. En hier zagen we dat er minder ontstekingstartende stofjes waren in de gestimuleerde dieren dan in de niet gestimuleerde dieren. En ook dit kan een verklaring zijn waarom de dieren minder pijn hadden. Op basis van dit onderzoek concluderen we dan ook dat in pijnlijke diabetische neuropathie-dieren langdurige conventionele ruggenmergstimulatie allereerst zorgt voor minder pijn en dit gepaard gaat met veranderingen aan het pijnsysteem. In het volgende hoofdstuk hebben we conventioneel, hoogfrequent en DTM-ruggenmergstimulatie met elkaar vergeleken in pijnlijke diabetische neuropathie-dieren, allereerst op pijnvermindering, maar daarnaast ook op de ontsteking in de ruggenmerg. Dit hebben we gedaan door gebruik te maken van hetzelfde diermodel en dezelfde test. En in deze grafiek kunt u duidelijk zien dat de dieren die niet werden gestimuleerd, de sham-dieren, meer pijn hadden dan de dieren die wel werden gestimuleerd. En die werden gestimuleerd met conventioneel hoogfrequent of DTM-stimulatie. Maar ook kunt u in deze grafiek zien dat er geen verschillen zijn in de pijnvermindering tussen de verschillende golfvormen die we hebben gebruikt. Daarnaast hebben we gekeken naar de balans tussen de ontstekingstartende en remmende stofjes in de ruggenmerg. Het was interessant om te zien dat in de dieren die met conventioneel werden gestimuleerd, de balans in de ruggenmerg uitsloeg naar de ontstekingstartende stofjes. Terwijl Hoogfrequent en DTM-stimulatie zorgden voor een balans naar de ontstekingsremmende stofjes. Op basis van dit onderzoek concluderen we dat in pijnlijke diabetische neuropathie-dieren conventioneel, hoogfrequent en DTM-stimulatie allemaal zorgen voor pijnverlichting, maar dit ook allemaal even goed doen. Daarnaast zien we dat het effect op de ontsteking tussen conventioneel en aan de andere kant hoogfrequent en DTM anders is. In het 5e hoofdstuk hebben we nogmaals gekeken naar de effecten van conventionele en DTM-stimulatie in pijnlijke diabetische neuropathie-dieren, maar in dit geval op de vetten. Vetten zijn de belangrijkste bouwstenen van cellen. En vanuit de literatuur weten we dat een verandering in de samenstelling van deze vetten een effect kan hebben op de balans tussen de ontstekingstartende en remmende stofjes. En daarmee ook indirect op het openen en sluiten van de poort in de ruggenmerg. Door hele dunne plakjes te snijden van de ruggenmerg en deze vervolgens te meten met een geavanceerde techniek genaamd massaspectrometrie imaging, kunnen wij heel veel verschillende foto's van heel veel verschillende vetten in de ruggenmerg tegelijk maken. En daarmee kunnen we de samenstelling van deze vetten in de ruggenmerg van verschillende groepen bepalen en met elkaar vergelijken. Omdat wij niet wisten wat het effect was van de pijnlijke diabetische neuropathie zelf, hebben we ook gezonde dieren meegenomen in dit experiment. Het was interessant om te zien dat in het onderzoek eigenlijk er geen effect was van de pijnlijke diabetische neuropathie op de samenstelling van de vetten. Maar als vervolgens conventioneel of DTM-stimulatie werd gebruikt, er wel een verandering plaatsvond op de samenstelling van deze vetten in de ruggenmerg. Op basis van dit onderzoek concluderen we dan ook dat, pijnlijke diabetische neuropathie-dieren de inductie van pijnlijke diabetische neuropathie niet zorgt voor een verandering in de vetsamenstelling. Maar dat conventioneel en DTM-stimulatie wel zorgt voor een verandering van deze vetsamenstelling. In hoofdstuk 6, het laatste hoofdstuk, hebben we weer gekeken naar de effecten van conventionele en DTM-stimulatie in pijnlijke diabetische neuropathie-dieren op pijngedrag. Eerder in deze presentatie vertelde ik u over de Van Vrij-test en dat dit eigenlijk een indirecte maat is van pijn, omdat we hier alleen maar de gevoeligheid meten. Deze test vertelt dus dan ook niks over wat het dier ervaart qua pijn. En in de praktijk blijkt het vaak lastig om behaalde resultaten vanuit dieronderzoek te vertalen naar de kliniek. En daarom hebben we in dit hoofdstuk geprobeerd met een andere test hier meer inzicht in te krijgen. In dit hoofdstuk hebben we gebruik gemaakt van de Condition Place Preference test, waarbij we de dieren een locatie laten associëren met pijnverlichting. In dit geval hebben we de dieren geleerd dat ze in de witte kamer wel ruggenmergstimulatie krijgen en dat ze in de zwarte kamer geen ruggenmergstimulatie krijgen. Als de dieren deze ruggenmergstimulatie als prettig en pijnverlichtend ervaren en we zouden de dieren vervolgens vrij rond laten lopen, dan verwachten we dat ze meer tijd spenderen in de witte kamer dan in de zwarte kamer. En dit onderzoek resulteert in dergelijke grafieken. En wij hebben dit gedaan met 2 verschillende groepen. 1 groep waarin we DTM-stimulatie hebben gebruikt en 1 groep waarin we conventionele stimulatie hebben gebruikt. Als de lijn omhoog gaat in deze grafiek, dan laat het zien dat het dier een duidelijke voorkeur heeft voor de stimulatie. Duidelijk is te zien dat in allebei de groepen er een aantal dieren zijn die een voorkeur laten zien voor de stimulatie. Maar ook is te zien dat niet alle dieren een voorkeur laten zien. En dat is interessant, omdat we vanuit het ziekenhuis weten dat ook niet alle patiënten pijnverlichting ervaren van ruggenmergstimulatie. En daarom denken we dat deze test misschien een betere indicatie kan geven voor de effecten van ruggenmergstimulatie op pijnverlichting en een betere vertaling kan zijn naar de situatie in het ziekenhuis. Op basis van dit onderzoek concluderen we dat de Condition Place Preference test het mogelijk maakt om pijnverlichting te meten, maar ook zien we hier eigenlijk geen verschillen tussen de conventionele en DTM-stimulatie. Dan wil ik u nog 1 keer meenemen met de belangrijkste conclusies van mijn onderzoek. Allereerst hebben we gezien dat langdurige conventionele ruggenmergstimulatie in pijnlijke diabetische neuropathie-dieren zorgt voor pijnvermindering en dit gepaard gaat met veranderingen aan het pijnsysteem die deze pijnvermindering kunnen verklaren. Daarnaast hebben we gezien dat conventioneel, hoogfrequent en DTM-stimulatie allemaal zorgen voor pijnverlichting en het ook allemaal even goed doen. Maar dat de effecten van conventionele ruggenmergstimulatie op de ontsteking anders is dan die van hoogfrequent en DTM-stimulatie. En hiermee ben ik aan het einde gekomen van mijn presentatie en geef ik het woord terug aan de prorector.
Hartelijk dank voor uw presentatie. The opposition will be opened by Professor Huygen, Professor Anesthesiology and in particular pain medicine at the University of Rotterdam. Professor Huygen was member of the assessment committee and we highly appreciate your participation to this academic ceremony.
Thank you, Mr. Pro-Rector. Dear candidates, first I'd like to compliment you with this work. I also want to involve your promoters and co-promoter in these compliments, but it's still not finished. Before I can congratulate you, hopefully within 1 hour, you have to defend your thesis. And for this defense, we have to change thoughts about the underlying work. And first I want to go to chapter 2. In this chapter, you describe a systematic review. And to estimate the bias in the identified articles, you use a risk of bias tool for animal research. And if we go to page 36 and look at the table, you show that there is a lot of bias. Luckily, you not only show this, but you also put attention to it in your discussion in this article. What my first question would be, what is actually now the meaning of this bias? And does this mean that we can neglect all the findings until now? Because it's really impressive, the bias, and say that there is no evidence for whatever, or can we still do something with these results of these articles?
Highly esteemed opponent, thank you for your kind words and for this question. It's something I think that we see in a lot of research, especially that has been performed in the past, that there's a high risk of bias. First of all, the risk doesn't mean that there actually is bias. That just means that there is a high risk. And I think we should not neglect these results. I think we only should interpret them with caution. And if possible, repeat these kind of experiments with excluding these types of bias. And I think we hoped to also do that with our own research, so we took into account most of these criteria for bias in our own research, and I think that helps a lot to the evidence. Furthermore, you see that there has been multiple papers describing similar results despite the bias that was introduced, and I think that also makes the case already a bit stronger. Although if you introduce the same bias each time, it might result in finding the same results because of the bias each time.
Is it not about certainty of the scientific conclusion? If there is bias, that, and especially if it's a lot of bias, does that not mean that there is uncertainty and that, because if there is no bias, then maybe the conclusion is very certain.
Yes, I 100% agree. Yeah.
Okay. Now let's go to chapter 3, because then you were already saying that in the past there were a lot of studies which had a lot of bias, and can you, if you take this table in chapter 2 in your mind, can we then walk through your study in chapter 3, and maybe you can do it, summarize it a little bit, because otherwise we go completely through the time. How is your study in chapter 3?
I think the study is definitely not perfect, but we at least tried to, where we can, adhere to the points risen in this risk of bias. So, for example, randomization, blinding of the experimenters. You have to have good concealment of which groups are allocated.
What are the limitations? Because, it's nice to hear what's good, but maybe you also can tell something about the limitations in this study, or are there no limitations?
I have to go back in my memory a bit, because honestly this research was performed already, actually the animal experiments were performed a long time ago. I have to dig my mind a bit.
Now let's forget about the limitations. Yeah, it's a beautiful day today. It's a special occasion. You are here. It has to be a celebration. So let's forget. I checked it, and what I've seen is that indeed, if you compare it to the earlier studies, that you succeeded to reduce the bias. So congratulations for that. But if we are in a situation that there is, as you did, that there is less bias, does that really mean that still, what you're doing results in the right conclusions? And a point of criticism I want to bring in is a point of criticism which comes from Ilona Obara from Newcastle University. You know her, of course, because she criticizes the model used in Maastricht due to the fact that she says that the Medtronic lead, which is used, the four-contact costume-made cylindric SCS, is not specific enough if you look at the structures which are stimulated. If you look at how big the lead is, then her point which she tries to make is that she says, yeah, you have no idea what you're stimulating. It's so big that it stimulates everything.
I think I have to agree to some extent that indeed it's relatively large, the amount of leads, the size of the leads that we're using compared to the size of the spinal cord. And indeed, I think we're stimulating way more than we expect, but I also think this is the case in the clinical situation. We are not stimulating only the dorsal column cells, for example, or only the dorsal horn cells. I believe that we are stimulating the full network. And also, if you compare the amount of electricity that we are giving the spinal cord, it's way more than the electricity that the neurons produce themselves. So it's almost like putting a bomb on the spinal cord in this case.
Okay.
Yeah.
If you look at the number of animals which is used in the study, and if you look at, you started by head with 36 animals, then you have to exclude those animals which do not develop hyperalgesia, and then in the end you have 5 to 5, and then still you have an infection, and so the limited of the number of animals from which you make conclusions is very small.
Yes, I agree. I think this is the big limitation in this study, is the amount of animals that we ended up with. We did a power calculation and we were expecting to end up with 8 per group, which already gives a way bigger basis to make the conclusions on. Nevertheless, we see that there are significant results, so statistically significant results in this research, in this paper. And I think that shows that the effect is actually rather robust and that the effect size is rather large because we are finding these results with this small amount of animals. Yeah. I think if we would have increased the amount of animals, we might even have been able to find significance between the sham and the conventional or the long-term stimulated animals in between the group, because that's something we don't find here. We only find over time within the group an effect. If I talk about the pain behavior, if I talk about the von Frey. Yeah.
Okay. Yeah, I look at the co-rector. Is there still time for a small question? Yes? Okay. My last question, and maybe you also can give a short answer, is about the motivational aspects of pain you also looked at in this chapter. In earlier research from the research group of your promoters, they showed that burst stimulation indeed has positive effects on motivational aspects. Why did you not study burst in this study?
So first of all, burst stimulation was not the scope of this study. We mainly focused on the inflammatory reactions. The inflammatory reactions, and we wanted to mimic the exact same situation as previously done by Van Beek, also in our lab, where he saw this long-term effects of conventional stimulation. And that's why conventional stimulation was chosen here as the paradigm.
Okay, clear. I'm very satisfied. Thank you, and I give the floor back to
Thank you.
Doctor.
The opposition will be continued by Professor de Geus, Professor Internal Medicine and particular Diabetes mellitus at this university. Professor de Geus was also member of the assessment committee.
Thank you very much, Mr. Prorector. Dear candidate, first of all, I'd like to congratulate you with your thesis, and I would also like to extend my congratulations to your promoting team. I think this is a very topical subject that you addressed, and very clinically relevant for people with diabetes, because this is a devastating complication of diabetes. That not always deserves or receives the attention that it deserves. So that's why I really enjoyed reading your thesis. But I do, of course, have some questions. Now, first of all, you already mentioned that in your presentation, the von Frey test. You used that test as a reflection of painful neuropathy. So how good is this test, or how poor is this test in comparison with painful diabetic neuropathy in people with diabetes?
Highly esteemed opponent, thank you for your kind words and for this question. I think it's a rather difficult question to answer. Of course, what we do in a clinical situation, we just ask the patients if they feel the pain. The most used is the FOS or the NRS scores. What's nice about the von Frey test is that it's very objective. It's because it's reflex-based, but we can never say that we are measuring pain. So yeah. That's a very critical point that we have to. Yeah,
the reason I'm asking that you show this monofilament, yeah. And we use the monofilament also in the clinic, but then just to see whether people can actually feel it or not.
Yes.
So we don't use it as a pain stimulus, but as a way whether they actually feel it. So it's completely reversed. But now let me go to chapter 6, because you realize that the von Frey test is not ideal, and it's what you say here in this answer as well. And then you use this place preference. Conditional place preference test. I didn't know it, but you explain it very clear, and also in the chapter. And I think this is it's a better test to sort of detect spontaneous pain. Now you use this test in chapter 6 to test the effect of conditional spinal cord stimulation versus DTM spinal cord stimulation, and then on page 158 you show the results. Now, if I look at the figure, and you also showed it here in the presentation. On average, I don't think there's an effect. Do you agree with me?
On a group level, there's definitely not an effect detectable for pain relief after either DTM or conventional spinal cord stimulation.
Correct.
I agree on that.
Correct.
Yes.
So there we agree. So now you said there were responders and non-responders, yes. Right? So there were 4 responders in the DTM and 3, I think, in the conventional, which showed an increase. But is it allowed to look at responders and non-responders if the average effect is not there?
I don't think it's a question whether it's allowed or not allowed. I think it's a good way to measure if there is an effect from the spinal cord stimulation, because there is undoubtedly an effect in this animal because it's its own control. So we can definitely say that this animal responded or preferred this spinal cord stimulation. And then I think if you make the translation to the clinic, it's especially highly relevant because we also see the non-responders and responders there. I think this test needs a little bit more fine-tuning. What I, in hindsight, would have liked to do is a pre-screening to see if the animals have spontaneous pain, because it's something we don't do now in this paper. We determined whether they had PDPN still based on the von Frey test. Right. And if we would have done that, we could have known, okay, they have spontaneous pain. Now we're going to give the spinal cord stimulation, and then we'll see if there is spontaneous pain relief from the spinal cord stimulation.
Yeah, that would be my next question, because I'll come back to the responder and non-responder issue, but my point was, does it mean the test is actually a good test, or did something happen with your pain in induction that the animals responded not as you would expect it normally?
I don't think there happened anything with the stimulation that caused the animals not to respond. I honestly think that it is a better predictor to see if animals actually prefer the stimulation. Right. Because as what you see, what I told in patients, we also have non-responders. So
if an animal does not respond, I would expect to see a flat line, right?
Yes.
But you also see animals where there's a downward line. Yeah. So that means that the intervention actually causes more pain. Is that what what the good conclusion is?
I won't say it caused more pain. I don't know, because we still can't ask the animals if it caused more pain. What we can conclude from that is that the animals did not or preferred not to be stimulated. That would be my conclusion.
Liked pain.
Well, we can also not say they like the pain, because we don't know. That's the major limitation in this study. What I said is that we didn't do a pre-screening, so we don't know if there is spontaneous pain in these animals.
So if you would have done the experiment again in those responders and non-responders, what would you expect the next time? Would they respond similarly, or do you think that regression to the mean could have played a role here?
It's a possibility that regression to the mean played a role, but I still think that there would be I would like to repeat the experiment with the same animals and see if they respond again, because then we can be certain if they actually prefer this kind of stimulation.
Exactly.
Yeah.
I have one final question, if I'm allowed to. Yeah. So what I also liked about this particular chapter, you used male and female animals. I think in the other chapters you chose to have male animals or female animals. I think in most animal studies they have a preference for male animals, and now you combine the two, which I think is a good thing. But you didn't talk about it at all, except in the methods. So why is that? I mean, did you look at the results of that? Did female animals respond differently compared to male animals?
I looked at the results, and there were no differences between the male and the female animals. That's also why I didn't report anything about it. Maybe it could have been a good add-on to note that in the discussion. But indeed, it's important to look at males and females, especially in this type of research, because we know there might be a different effect between males and females. And it's also something we highlight in the general discussion of the thesis. We didn't do it in the previous chapters, so chapter 3 till 5, for various reasons. So, for example, chapter 3, the study is very extensive, very long. So to get to this amount of animals, it already took more than a year of experimental work. So it would have been the same amount of time to add also female animals. And then we know, based on historical data that we have in our own group, that it's easier to induce PDPN in females compared to males with this model that we're using. So in the other chapter, so in chapter 4, we chose to first do the female animals to make it easier actually to induce and to get a higher amount of animals that actually develop PDPN. Then in chapter 5, we used again male animals to see, at least at the behavioral level, because this experiment, the test of experiments was exactly the same as in the chapter 4, to see if there was at least a difference in the behavior, and there we don't see any differences. And then, if I may come back to chapter 3, we also chose to use male animals here because we used an IPG, which we implanted, and of course male animals get way larger, way bigger, so it's ethically better to use male animals if we implant an IPG there. Yeah.
Okay, thank you very much. I have a lot of other questions, but I think Madame is upset. I get the word back. Thank you very much.
The opposition will be continued by Dr. Jahan Shashi, Associate Professor Neurosurgery at the Maastricht University Medical Center. Dr. Jahan Shashi was also a member of the assessment committee.
Dear candidate, I also want to congratulate you and your promotion team for this PhD thesis. For the sake of time, I directly address my question to you. So my first question regards the rationales behind the choice of the animal model. Is not the easiest model, and we all know that there is no perfect animal model. There is no animal model that can precisely mimic human condition. Having this said, you have used the STZ-induced model. That one of the major limitations of this model is high variability among the subjects. Although I mean, almost 40%, 60% of the animals didn't respond to the model induction, but among those 40%, there are like I suspect that there must be quite some variation. And do you think this variation between subjects might have played a role in your behavioral data and also the molecular assessment? Especially, there are some negative data. And do you think if you would have used alternative statistical method and analysis other than just comparing the groups, you could have better, you could have picked better the therapeutic effects of SCS.
Esteemed opponent, thank you for your kind words and for your questions, actually. So I hope that I can recall all of them. So first, towards the animal models that we choose is actually a type 1 diabetes model. It might be clinically less relevant because we see in the clinic that type 2 diabetes has a higher chance of developing PDPN. But it's the easiest model for us, or it's the model that has been used in the past the most to study PDPN, and it also results in the maximum or the highest amount of numbers of animals that develop PDPN on the short term. So ethically, it's the most suitable animal model. And then regarding the variability of the data, of course, we see that there is variability. I do not know to what specific test you are referring, but if you refer to the, for example, I don't know if it's
so comparing the Western blot data, for instance, we compare the groups instead of looking into like applying more inter-individual and like within subject comparison.
Yes. So for the behavioral data, we check both within over time to see if they, first of all, if they develop the PDPN, and then if we do spinal cord stimulation, if within the group there is an effect. And then we also do between, so versus sham stimulation, or in chapter 4, between conventional high-frequency DTM and sham stimulation. So we choose both options to see if there is an effect within the group or between the groups. Yeah.
So do you think this variability, you can turn this around and work more towards more personalized application of spinal cord stimulation and apply more stimulation on demand and kind of adaptive stimulation?
Yeah, so I know that that's something that's been researched now quite a lot is ECAPs, to always be in a therapeutic window for the amplitude that we are stimulating with. So what we do now is we measure the motor threshold. In, for example, chapter 4, we measure it every morning and we stimulate for 48 hours. And then we stimulate that day for 50% of the motor threshold. Of course, we don't know what happens if they stand up, if they lay down, because then the distance between the lead and the spinal cord might differ, and that might also have an effect on the actual dose delivered. So there, ECAPs could be a solution, although that's a little bit more difficult for paradigms which are below perception threshold. So that's a way to maybe overcome this individual variation. And I also think that in the future we should think about optimizing the treatment for each patient, but then I'm talking about patients with these types of paradigms that we're using, because one patient might benefit from conventional and the other might benefit from DTM more, and then it should be a patient-fit solution, I think. Yeah.
Thanks. For the second question, again concerns chapter 3 and 4. And you apply two different stimulation regimens in these two chapters. One, in chapter 3, you apply 4 weeks of stimulation, is chronic stimulation. In chapter 4, the conventional stimulation is only a couple of days. Yep. You see similar behavioral outcomes, both on pain and the motivational aspect of pain. And but the effect on inflammatory pathways are somewhat different. So how do you justify this? Do you think that there are different mechanisms are involved, or inflammation probably is not playing a role here?
I have been thinking about this a lot. So there indeed are two things to take into account. First of all, the time that we've been stimulating. So in the experiments from chapter 3, we've been stimulating for 4 weeks. And the experiments in chapter 4, we've been stimulating for 48 hours. So, for example, we know that microglia respond in a faster way. So it could be that there's a difference here that which causes the difference we see on the inflammatory pathways. On the other hand, what we do in the 4-week stimulation is that we only stimulate for 12 hours per day. And we stimulate for 12 hours per day, so 12 hours on, 12 hours off. And we do this for the long term. And what to me was interesting here is that we also see that after this long-term stimulation, even if we turn it off, there is still an effect, which makes us think that these changes that we see, both on the neurons and maybe also on the BDNF, causes this long-term effect even to be abundant when we stop the stimulation. And with this 48-hour stimulation paradigm, we do it continuously. So there might also be a difference here, which can cause the found differences on the inflammatory pathways.
Can I have one more short question? So regarding these plastic changes, sometimes in the clinic, the stimulation has to be discontinued for various reasons. Would you expect withdrawal symptoms if in patients who has been receiving this, based on these mechanisms that you discuss here?
I think they might come back on the long term, especially with PDPN patients, because we didn't treat the diabetes, right? So the neuropathy might come back. There might be, again, damage to the neurons. But what for me would be interesting here is to investigate if we can shorten the amount or titrate the amount of stimulation that we can use for these patients and do an on-off period continuously to see if we can induce these plastic changes. And if they are there, we can turn it off for a while because they are there. Yeah.
Thank you very much.
Thank you. The opposition will be continued by Dr. Kremers, Associate Professor Orthopedic Surgery at the University Medical Center of Utrecht. Dr. Kremers was member of the assessment committee, and we highly appreciate your participation to this ceremony.
Thank you, Mr. Prorector. So, dear candidate, of course, also from my side, congratulations with this extensive body of work and thorough as well, I have to say. And of course, I would also like to extend this towards your promotion committee. I have one especially burning question, talking about inflammation. And you maybe know that I've been working on NSAIDs in osteoarthritis, and we found that it works miracles when you put this directly into the joint. And with every chapter I was reading, the fire of my burning question was actually getting larger, because everywhere you say that the pain associated with the painful diabetic polyneuropathy is related to inflammation. But on the other hand, I suppose that all these patients have tried all over-the-counter NSAIDs that you can imagine. So why doesn't that work if inflammation is so important?
Esteemed opponent, thank you for your kind words and for this question. I think it's a difficult question to answer. We indeed see that if they take anti-inflammatory drugs, that it doesn't work. Of course, there's also systemic drugs. And I don't know how well they, I'm not a doctor, how well they will act on the spinal cord itself. Secondly, there are more processes going on. The nerve if you give anti-inflammatory drugs, it won't change the nerve damage done in PDPN patients. So there will be still continuously a signal, a pain signal going towards the spinal cord, which might also adapt these processes in the spinal cord.
Mm-hmm.
Yeah.
Okay. You think there may be some kind of window of opportunity still to start with anti-inflammatory drugs before
the central sensitization processes happen?
Yeah, exactly.
Rather than I think it might be a good opportunity to study this, but then again, also here we don't treat the diabetes, the root cause of the neuropathy, which causes the pain itself. So then it has to be an add-on treatment, I think. Yeah.
Okay, that would be my other questions, whether you think there would be a future for combining both types of treatments. So the answer would be yes, combining neurostimulation with pharmacological treatment.
Yeah, I understand your question. Here I was not talking about the stimulation, I was talking about treating the diabetes. Mm-hmm. But indeed it could be of beneficial, it could be beneficial to have anti-inflammatory drugs together with the spinal cord stimulation if you, for example, see that the patient is not benefiting from the spinal cord stimulation on the long term. Because I think the effects of the spinal cord stimulation on inflammation, for example, from the conventional stimulation, what we see on the long term might cause that we have this drop in efficacy. So if we there would have the add-on from anti-inflammatory drugs, it might prevent this long-term decrease in efficacy.
Okay. So maybe there is some modulation possible. Thank you. After that, relieving that question, I would like to go to chapter 3. And in particular, I was a bit puzzled about your statement that there is a discrepancy between the enduring pain relief, which is 24 hours after removing the stimulation, versus the loss of pain relief in patients after 2 years. And do you think that this is really a discrepancy? Because as far as I can see, the loss of pain relief in patients is the loss of pain relief of the stimulation and not after stimulation. And this 24 hours, just shortly after stimulation, is quite different. So do you really think there is a discrepancy?
I think these are indeed two different processes that we see on the long term in patients, that there is a decrease in efficacy, and here we stop the stimulation and we still see that there is an effect. Although now, if you put it in this way, and I think about it, if we have a wear-off of the effect of stimulation, or if there is no effect anymore of stimulation, no more progress to be made, and the pain or the neuropathy increases, and therefore the pain increases, that might also cause the loss of long-term efficacy of spinal cord stimulation.
Okay, so the discrepancy you see here then is that in the animals themselves, the stimulation still works as well over the 4 weeks studied.
We see pain relief,
Whereas in the patients you don't. Okay, that makes sense. And one small question I had is because you refer to other studies showing this pain relief 24 hours after switching off the stimulator. You never considered looking, for example, for 48 or 72 hours? Or
That's a very interesting question. I think it's for further research. We could look into a different set and test, see what the wear-off time is. Yeah, okay. But for now, so to explain a little bit why we did it this way, because we want to also look at these processes for the neurons in the skin and for the inflammatory process in the spinal cord. So we chose this 24-hour window to be able to see if now there is still an effect, let's see what processes might be behind that.
Do you think you would have lost those effects after longer periods of time?
Well, that's also an interesting question, because I don't know what would happen after 48 hours, 72 hours with, first of all, the pain behavior. So then I also won't know what will happen with the inflammation or the amount of neurons in the nerve fibers in the skin.
Okay. All right. I think I have lost all the time left.
Thank you. The opposition will be continued by Professor van de Beuken, Professor Palliative Medicine at the Maastricht University Medical Center, and Professor van de Beuken is also the secretary of the degree committee.
Thank you. Dear candidate, I too would like to compliment and congratulate you on your thesis. You worked in a research group that has a strong focus on translational research. And despite describing the results of your basic world, the translation to the clinic is always readily apparent. Having said this, I immediately see a big problem with the translation in the clinic. In the Netherlands, the prevalence of diabetes type 2 is 1.1 million patients, and you told us 25 of them develop painful polyneuropathy. Pharmacological treatment is only given relief in 50%, and then that brings us to 140,000 new implantations costing about 25,000 euro each. So we have a catch-up to do of 3.5 billion. I don't think you make friends with the insurance companies. What should be our strategy in this?
A highly esteemed opponent, thank you for your kind words and for this question. It's actually something I never thought about, what it would implement for the healthcare cost. I think we still should consider spinal cord stimulation not a first option for treatment. I think there is cheaper medication that might also work in these patients. So I think we should in the future look how to select, maybe even in an earlier stage, which patients might benefit from this spinal cord stimulation.
That is a little bit reassuring, but maybe one of your paranyms can read out statement 5.
Long-term spinal cord stimulation induces structural changes to the nociceptive system in the spinal cord, which opens the door to exploring whether or not spinal cord stimulation could not only minimize chronic neuropathic pain, but also prevent the development of neuropathy in PDPN.
You already feel where this is going.
Yes.
And now, in addition, with these 140,000 implants for pain, you want to start preventively. So what has to happen? What do you have to do in the lab before we doctors even start to think about it?
Yeah, I don't know, yeah, it's of course lab work. I don't know if it should be animal experimental work, but maybe we could look into biomarkers to select which which subgroup of patient population has the highest risk of developing these symptoms, and select in an early stage, this was where I was going, in an early stage, the correct patient for this treatment. Yeah.
But don't you think we have to do much more lab work to see if really preventive
Of
is?
course,
Of
yeah,
course, yes,
course,
that's what I am
yes,
hinting
yeah.
of.
Yeah, actually, that's something we have been discussing and also thinking about, to set up an experiment to see if there are actually preventive effects of the spinal cord stimulation. So the way we would do that is implement in an earlier stage, so shortly after we do the diabetes induction, yes, and then see if these animals that are stimulated develop the PDPN or not. And then compare, of course, with a group which is not being stimulated.
Yes.
Yeah.
And then you can give us...
Yeah.
Well, because of time, I won't bother you with chemo-induced polyneuropathy, and I'll give the word back to the co-rector.
Thank you. The opposition will be continued by Dr. Van Mierlo, Associate Professor Neuroscience at the Maastricht University and the University of Hasselt.
Thank you, Mr. Prorector. I would like to congratulate the candidate and the promotion team by extension with a very nicely written thesis. I think you used state-of-the-art methodologies to come to your conclusions, so congratulations on that. But of course, today I'm not only here to give you kudos, I also like to ask you some questions and discuss some topics which you describe in your thesis. So in the introduction, you also refer to the process of sensitization underlying PDPN in the central nervous system. And can you perhaps explain this concept and reflect on perhaps on the role of epigenetics, which they might play in this process?
Esteemed opponent, thank you for your kind words and for the question. So the process of central sensitization is the strengthening of neurons in the spinal cord, especially in lamina 2 dorsal horn neurons, which causes an easier transmission of pain signals. Now, I'm not really an expert on epigenetics, but of course there could be a role here. We know, for example, from other pain research in neonates that in neonatal pain might have an effect later in life when there is re-injury, and this could be, of course, epigenetic related. So I think there might be a role here, but in the context of PDPN, I'm not really aware of what the status is on the research of epigenetics and the role for the development of PDPN and with regard to central sensitization.
Okay, thank you. So let's say epigenetics might play a role because the genetics doesn't change, so likely something epigenetic is changing. Would you consider epigenetic editing as a potential treatment strategy in PDPN?
Of course, if one of the causes for the central sensitization is an epigenetic change, then epigenetic editing might also be be an important treatment option. But that really needs further research, which is not my type of expertise now. Sorry.
All right, thank you. Then that brings me to chapter 3. So in chapter 3, you used the STZ-induced diabetic model in Sprague-Dawley rats. What struck me the most, and as has already been discussed, I didn't know, that almost half of them only respond. We already discussed the responder rate or the rate on which you can expect symptoms or not. So this also brings me back to epigenetics because again, these animals have the exact same genetic background. And I was thinking, would there be a clue or an answer in the questions we're looking for in the ones who don't show this pathology?
Yeah, that would be also an interesting future research to see if there indeed is an epigenetic difference between the animals that actually develop the painful symptoms and the animals that don't develop the painful symptoms. Yeah, it could be part of research. And with the responders, you were referring to the PDPN itself, so the pain symptoms, or were you referring to the spinal cord stimulation responders?
In this case, I was referring to the pathology being developed. Yeah. Okay, fair. Thank you. I think we agree that there's some space there for future research, of course. Yes. All right. Then I would like to go to figure 3.4 on page 77. In this figure, you display some figures in which you examine the nerve fibers sprouting in the hindpaw skin. The data is displayed as intraepidermal nerve fiber density, right? Yes. So expressed as fibers per millimeter for 2 proteins. And when looking at these figures, I could not discriminate the individual fibers on the image. So I would like to hear from you, is this really the number of fibers per millimeter that you could quantify, or is this based on mean fluorescent intensity?
So how we quantify this is that you can see the border between the dermis and epidermis. And actually, I have to say on the computer, it's better you can see it better than you can see it in this thesis. So we draw a line on the exact border, and then we count the fibers, which we can clearly see, because on a microscope, you can also zoom in and zoom out. And of course, you're in a 3D layer. Although it's only 30 micrometers thick, you can still zoom in and zoom out a bit. And then you can see the fiber sometimes going like this. And then we can clearly see if this fiber is crossing this line that we predetermined or not. And that's how we calculate it. And then we also calculate the length of this line, and then we divide the amount of fibers by this length. Okay, that's how it's supposed to be.
Very clear, so not based on the picture itself, right?
Not on these pictures. So actually, I don't base it on pictures, but it's like live zooming and working on the microscope to do this.
Makes a lot of sense. Yeah. Thank you. Next, in figure 3.5, you look into spinal cord dorsal horn homogenates to assess the activation of microglia and astrocytes. So you make homogenate, you do Western blot, and you look at protein expression. And I was wondering, is this the right way, or the best way, I must say, to see whether your microglia and astrocytes are actually activated? Or in hindsight, would you perhaps use additional approaches?
So in this case, we chose this option to be able to quantify the amount. So activation might not be the best term, especially because the marker, for example, for microglia that we use is EBA1, which is just a general marker for microglia. And I have to be honest here that we were looking into another marker, OX42, which is more representative for activated microglia, but we were not able to make the Western blot work for that marker. What's nice about doing it this way is that we can look at all these different proteins with Western blot from the same homogenate. So one animal gives us way more information than if we do a staining, for example.
And could you comment on what additional information you could derive from a staining, if you could do it?
Yeah, if you do look at the morphology for microglia, for example, you can clearly see if they are activated or non-activated. There are stages which you can qualify on. Yeah, but that's
so that might add an additional layer to the information.
Yes, but of course that's a completely different technique. So if we would use that, then we have to use more animals. Yeah.
Thomas de Geus, de gelegenheid voor het verdedigen van uw proefschrift is voorbij. De promotiecommissie zal zich nu voor beraad terugtrekken en ik verzoek u en uw gezelschap onze terugkomst en de uitslag van dit beraad in deze zaal af te wachten.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
the south side. 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. All your time, 'cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Hit the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. Even though these nights seem long, I know that I am never on my own. Know you won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goal's only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Jacobus de Geus. De commissie hier aanwezig heeft zich beraden over de kwaliteit van uw proefschrift en de wijze waarop u dat proefschrift heeft verdedigd. Op grond van haar positief oordeel en gelet op de examens die u vroeger heeft afgelegd, heeft zij besloten u het gevraagde doctoraat toe te kennen. De hoogleraar, professor Joosten, is gemachtigd u op de gebruikelijke wijze met deze waardigheid te bekleden. Het woord is aan uw promotor.
Belooft u dat u altijd volgens de beginselen van de wetenschappelijke integriteit te werk zult gaan? Eerlijk en zorgvuldig, transparant, onafhankelijk en verantwoordelijk?
Dat beloof ik.
Krachtens de bevoegdheid ons door de wet toegekend, volgens het besluit van de commissie, hier tegenwoordig, verklaar ik hierbij u, Thomas Jacobus de Geus, tot dokter te bevorderen en u alle rechten te verlenen die daaraan volgens wet en gewoonte zijn verbonden. Ten bewijze hiervan overhandig ik u nu de bul, door rector, secretaris en overige leden van de promotiecommissie ondertekend en met het grootzegel van onze universiteit bevestigd.
Alle goede dingen bestaan uit twee, Thomas. Namens het onderzoeksinstituut MENS, Mental Health and Neuroscience, ben ik tevens gemachtigd om dit officiële certificaat uit te rekenen. De eigenaar van dit certificaat heeft aangetoond een brede opleiding academische vaardigheden te hebben ontvangen en relevante ervaring te hebben opgedaan die bijdraagt aan een succesvolle loopbaan als zelfstandig onderzoeker. Proficiat.
Beste dokter Thomas, het is een bijzondere dag. Je hebt een voortreffelijke prestatie geleverd met dit mooie boekje en je uitstekende verdediging. Ik wil niet alleen jou feliciteren, maar ook je moeder, je vader, je oma is ook hier, geloof ik. Je broer, je vriendin Anouk en zeker ook de verdere familie, vrienden, kennissen en collega's. Deze laudatio heb ik getiteld Onze kopman in Parijs-Roubaix. Een PhD-project is te vergelijken met een wielerwedstrijd. Een zware wedstrijd. Een moeilijke koers. En dan zeker de zwaarste eendagse wielerkoers die er is. Een monument Parijs-Roubaix. Daar kun je het mee vergelijken. Jij als liefhebber en amateur, vele kilometers in je gesoigneerde beentjes, was klaar voor de strijd. Je had de juiste kwalificaties en diploma's om in het wielerteam van de experimentele pijn een belangrijke rol te kunnen gaan spelen. Maar je weet nooit hoe de koers zal verlopen en hoe die uiteindelijk, en zeker bij Parijs-Roubaix, in de volksmond niet voor niets de hel van het noorden genoemd, uiteindelijk gewonnen kan worden. Want dat is de bedoeling. Liefst alleen aankomen op de wielerbaan, de velodroom, in Roubaix aan te komen en dan een soort van ereronde te rijden. Zegevierend de bul in de hoogte te houden. Waarbij het alom aanwezige publiek de handen kapot klapt voor deze geweldige prestatie. Zou dat nog een keer kunnen? En even dat ding omhoog houden. Want dat is de bedoeling. Het begint met de ploeg. Dat is de zaak van de coach. Het samenstellen van een goede groep van onderzoekers die indien nodig voor elkaar werken. Knechten, kopmannen en waterdragers. Bij deze zware koers waar we voor stonden, deze Parijs-Roubaix, deze hel van het noorden, werd jij aangewezen als kopman. En de andere teamleden hadden de taak als knecht of als waterdrager te fungeren. Doel? Thomas de Geus liefst alleen zegevierend over de finish te krijgen. En gelukkig hadden we een goed team met onderzoekers die als knechten voor elkaar wilden werken waar nodig. Roos, Lonne, Martijn, Glenn, Mathilde, Koen, Nienke, Roel, Perla, Imke en Maite. En als een goed en hecht team zitten ze bijna allemaal hier in de zaal of ze zijn zelfs paranimf geworden. En dus, een kleine 4 jaar geleden begon voor jou en voor het team deze aflevering van Parijs-Roubaix. En wat blijkt? Het is eigenlijk helemaal geen hel van het noorden geweest. Jij, Thomas, was zo goed voorbereid en je had al zoveel kilometers in je getrainde benen dat de koers bijna perfect en volgens plan verliep. Er waren wel eens kasseienstukjes waar het even wat minder ging, maar dat is het noemen niet waard. Bevreesd was ik als coach voor de fameuze kasseienstroken, zoals het bos van Wallers, waar de complexe experimenten van Maarten van Beek en de langdurige stimulatie van het ruggenmerg in de diabetedieren herhaald moest worden. Maar dit werd door de hulp van je knechten en vooral door jouw geweldige stuurmanskunst werden dit makkelijke passages. Het was prachtig om te zien hoe jij deze experimenten gedreven en geconcentreerd op een perfecte wijze hebt uitgevoerd. Chapeau. De resultaten van Maarten van Beek werden gereproduceerd en verder uitgediept. En dat is misschien wel het belangrijkste criterium van goed onderzoek. Dat werd nu bereikt. Reproduceerbaarheid van data en bevindingen. Maar de koers heet niet voor niets de hel van het noorden. De grote kasseienstroken in de laatste 50 kilometer moesten nog genomen worden. Die waren wel zwaar. Het is het einde van de koers. En met de massa-spectrofotometrische analyse van eiwitten en lipiden in het ruggenmerg van diabetes gestimuleerde dieren, in samenwerking met Eva Kuipers en Ron Heren van M4I, lagen daar toch nog een paar pittige uitdagingen. Vraag maar na aan Mathilde, aan Martijn, aan Glenn. Maar ook hier ging jij, onze kopman Thomas, met een niet aflatende en geconcentreerde instelling over de kasseien. Alle mogelijke valpartijen vermijdend, om daarmee zegevierend over de finish te komen. En dat is vandaag een prachtige prestatie. Je hebt een stelling meegenomen van Gino Bartali, een van de grootste Italiaanse wielrenners aller tijden. Maar ik vroeg me af, waarom Bartali? Toch denk ik het nu te weten. Bartali was een geweldige renner, maar hij bleef bescheiden, godvruchtig en eerlijk. Vandaar zijn bijnaam, de zwijgzame, de vrome, de mystieke of de monnik. Mogelijk herken je hier zelf in. I don't know. Maar jammer genoeg heeft Gino Bartali nooit Parijs-Roubaix gewonnen. Bedenk dat zijn tijdgenoot, zijn tegenpool, de door glamour en show en grootste rivaal Fausto Coppi, bijgenaamd Il Campionissimo, in 1950 wel een keer als winnaar op de velodroom van Roubaix is aangekomen. Net als jij vandaag. Geef het woord terug aan de prorector.
Dokter de Geus, het is mij een groot genoegen om u namens de Universiteit Maastricht en het College van Decanen van harte geluk te wensen met de behaalde dokterstitel. Het is al duidelijk geworden tijdens de laudatio dat u een wielerfanaat bent. En wielerfanaten, zoals stelling 9 aanduidt, die gaan voor medailles. Ik hoop toch dat u deze bul en het bereikte dokterstitel, dat dit eigenlijk ook in de toekomst beschouwd wordt als een medaille en dat het will be pinned in your soul. Hiermee zal ik de academische zitting sluiten. Ik wil vragen aan de toehoorders om het gebouw te verlaten. Wij zullen met de jonge dokter nog een foto maken op de trappen in de centrale hal. Hiermee sluit ik deze academische zitting.
The PhD